Okay, so when we do GBS, let me tell you all at the very get-go that we definitely get around 2 to 3 questions from septicemia, in which the early onset from listeriosis, every time they give one question, because we've got a beautiful Irish guideline from Listeria. And that guideline, those recommendations are nowhere, neither in the European board nor we have in the Green Top guideline. So that's a wonderful guideline. They always give you some questions from Group B Streptococcus. 100%, Sheila, GBS comes from the interpartum antibiotic prophylaxis exam scenario. If you have a good grip over that when to give IAP and when not to give IAP, you would not face any difficulty. So I'm telling you today that out of 100 questions, you'll get 3 questions in different types of scenarios, sometimes urinary tract infections, sometimes a septicemic baby, sometimes a patient with old septicemic baby and now coming up in this pregnancy, or sometimes with the labor questions of prolonged rupture of membranes. Are you guys with me? How do they just play around this topic? So the first thing is that you need to have 100% grip over GBS. You should be knowing that what are they asking for and where we need to put a stress. And moreover, the guidelines which are updated in January 2023, there were 12 guidelines updated, including the urogynecology. They are amazing set of algorithms which college has given, wonderful description and very important, because even in the recent May OSCE 2023, they touched those points. That shows that how important these topics are, right? So we're going to do the National Clinical Practice Guideline, the prevention of early onset Group B streptococcal disease in term infants. Why did I select this topic? Because that's super important. Why did I select this topic? Because it's a tiny one in recommendations as well. So we'll try to complete it in 30 minutes so you understand that how we have to do. If you see the publication date, guys, it's January 2023, from where this tells us that this is the recent one. Okay, let's begin step by step and let's understand where we would be deviating from the Green Top guideline. I would tell you that please note this point. This is an important point for exam. Now, to begin with, they say that early onset Group B streptococcal disease in infants, we should have a set criteria of the GBS screening options. What's that? The risk factor based screening. If the patient has got risk factor for having GBS, or risk factor based screening, which is enhanced by PCR. That testing, especially when the patient has got some prolonged rupture of membrane, or she's being induction of labor is being done in that case. And then we have a universal culture-based screening for the patients who are approaching 35 to 37 weeks of gestation. Now, the question comes from when to give IAP, when we don't have to give IAP. In this, we need to understand that IAP is for all patients who have urinary tract infection. And we come to know that this bacteriuria is GBS. When GBS bacteriuria is there, we need to give IAP. But how do they give exam question? When GBS urinary tract infection is there, we require IAP for all patients, no matter that it is less than 10 raised to power 5 colony forming unit. The recommendation says that we recommend the IAP offered for GBS bacteriuria of any colony count in the current pregnancy. Do you guys understand that what does this line mean and how it differs? There will be 2 exam questions. First of all, please tell me that everyone who is here, maybe somebody is not from MRCOG who is taking this exam for the first time. Guys, aware of what IAP stands for? Let me do a little snowballing. So are you guys knowing that what IAP is, so that I'm clear that when I'm taking this word, when I'm using this word, everybody in the audience is pretty sure that what are we talking about? IAP is intrapartum antibiotic prophylaxis, which is the name given to the GBS prophylaxis for the patients. Clear? Shazia? Ifat? Amazing. Shaista? That's perfect. Great. So you guys need to understand that when we talk about the intrapartum antibiotic prophylaxis, now in MRCOG, they do not say in the GTG that all patients will get IAP with bacteriuria. Here, we have two different set of patients. Please pay attention here. If they give you any patient in exam with urinary tract infection, the red color is visible, guys, or shall I change it to black, please? Is the red ink for the pen is visible to you? Yeah, it's visible? Okay, great. That's fine. Okay. So if UTI, it's there, you people will select IAP for all the patients who have the urinary tract infection, provided they do the culture sensitivity and in the culture, it comes out to be GPS. Am I clear? Yes. For all patients who have the bacteriuria with GBS, 100% would be given intrapartum antibiotic prophylaxis. Is this point clear? But if in exam, they give you that GBS UTI is there and they give you CFUs, the colony forming units of 10 raised to power 5, more than 10 raised to power 5, then Zainab, we won't select only IAP. Then we would select the moment she presents to us. When she presents to us, at that time, we need to treat the bacteriuria for her as well as an antenatal treatment. And later, when she goes in labor, we would give IAP as well. So now how the question comes from these two as a single best answer? The first question that comes from this is, number one, if the patient, she has bacteriuria, GBS bacteriuria, they would give you option A, that please give IAP. Option 2, antenatal treatment now and IAP. So you should be very clear that if it's only GBS bacteriuria, then it is going to be intrapartum antibiotic prophylaxis. This option would be chosen. But if it is 10 raised to power more than 5, then you will choose now antenatal treatment as well, plus IAP. So that option would be the best option. Could I make myself clear that how do they twist the single best answer? They twist the single best answer at times giving less than 10 raised to power 5, but bacteriuria is there. If it's less than 10 raised to power 5 and bacteriuria GBS is there, then only IAP would be selected. Is this point clear? But if it's more than 10 raised to power 5, then with IAP, now she needs to be treated in her pregnancy when she presents with that urinary tract infection as well. Am I clear when to select alone IAP and when to select with IAP, the antenatal treatment as well? Could I make myself clear in which option you would choose antenatal treatment plus IAP? And in which option you would choose only IAP? This is the first mistakes the students they do because they're not aware that antenatal treatment would be when it's more than 10 raised to power 5 colony forming unit. Right? So that is what you guys need to remember. Okay? So this is what you people have to remember in exam. Absolutely. For IAP, for any count, my dear Shazia. For IAP, for any count would be IAP for urinary tract infection. All right? So they say that we recommend that IAP be offered for GBS bacteriuria of any colony count in the current pregnancy. And we recommend that both GBS UTI and asymptomatic GBS bacteriuria, which is more than 10 raised to power 5 colony forming unit, requires antenatal treatment. Okay, so when it is more than 10 raised to power 5, then antenatal treatment would also be added with IAP. Got it? IAP plus antenatal treatment means, for example, she comes at 24 weeks of gestation, right? If she comes at 24 weeks of gestation and she has UTI symptoms, you come to know, you do the culture, you check it out, and it's more than 10 raised to power 5 colony forming unit, GPS. What would be the answer? In this patient who has come at 24 weeks with urinary tract infection, you people would select at the moment now at 24 weeks, she would have the treatment of GBS UTI, right? This is known as antenatal treatment. What is this? The antenatal treatment. Plus, you're going to select when she goes into labor, she will have IAP, when she would be going in established labor. Do you guys understand? So now would be the treatment, and this is the only recommendation where we have antenatal treatment plus intrapartum treatment as well. But please remember, the count should be more than 10 raised to power 5 colony forming unit. Is it clear now, Rosina? Yes, clear, Afshi? That's amazing. Thank you so much. Now, about bacteriuria, this is one indication about GBS. But other than that, we have other indications as well. And in other indications, we get that GBS vaginal colonization. So when the patient has got GBS in the current pregnancy, if the patient has got GBS in the current pregnancy in the swabs, in the vagina, would we give IAP or we would not give IAP? Presently, she is having GBS. In the current pregnancy, she has GBS as per the vaginal colonization. We should give or we should not give? Very good. If in the current pregnancy, she has it, we have to give IAP to her. What is the reason for that? Because the baby can have an effect. The baby can suffer as well. All right. So any patient in the current pregnancy, if has GBS, would be given IAP. Now, this is for the current pregnancy. If the patient does not have GBS now, but if they give you an exam question, in the past pregnancy, in the previous pregnancy, she had GBS. In that situation, the guideline says it's 50% of the chance that she might be positive, and there's a 50% of a chance that she would be negative because in the previous pregnancy, she had GBS. So it is recommended that you offer a choice that you want to get screened again, or we take that 50% of the benefit of doubt and we offer you IAP. So in this case, we can select repeating the GBS screening for the current pregnancy now, or we can give IAP to this patient as well. Do you guys understand? This is for those patients who had GBS in the previous pregnancy, right? In the previous pregnancy. Let's revise that once again so that you people have a very clear recommendation in your mind. Okay. Now, this is a patient here, and in this, if it is going to be for this patient, no, Madina, my dearest, MRCPI going on, sweetheart. Yeah, go to the premium, my dear, discussion is started, sweetie. All right. If this is the patient, and for this patient, if she has GBS vaginal swab in the current pregnancy, now, GBS vaginal swab, it's positive. At the moment, it's positive, please. What would you do for this patient? Now she's GBS positive for vaginal swab. Very well done. This goes for IAP for exam. Very well done. Now, if I say that we've got a patient in the single best answer, and in her previous pregnancy, she had GBS positive. Not now. Sophia Tariq, in the previous pregnancy, my dear. Shazia Shahid, in the previous pregnancy, she had GBS positive. Now you will give her an option either to get tested, yes, either to get tested or to give IAP, because 50% is the chance that she comes out to be positive and 50% is the chance that she is negative. Understood? If in the current pregnancy she would be in the single best answer, we would give IAP. And if the previous pregnancy she was positive, this time it's recommended to do the testing. So it's better to test this patient rather than doing the IAP. But if she's not agreeing to the test, she says that take the benefit of doubt and please do the IAP, we would do IAP for this patient. Very well done. Thank you very much. Now, let's go to the next recommendation for IAP. Now, If the patient is known GPS carrier and with preterm labor, spontaneous rupture of membrane, we definitely would give IAP. That would be induction of labor as soon as it's possible. So if the patient who is positive for GPS, and if she gets the rupture of membranes, we try to do the induction of labor as early as possible, because we don't want that the membranes are ruptured and the baby gets exposed to the GPS, right? Therefore, if she is positive for GPS carrier, early induction of labor is done. We don't wait for those 24 hours, which we generally do for the patient, right? Now, we generally tell the patient that we offer IAP if she had the GPS colonization in the current pregnancy, which means what? Either in the urine or in the rectovaginal swab, as we have discussed, or if she was in the previous GPS colonization in the previous pregnancy, and she this time is not ready for the screening. All right. This time she says, I'm not ready for the screening. So the same point as we've discussed earlier, either she's colonized in this pregnancy, we will give IAP, or in the previous pregnancy, she was colonized, and this time it is going to be, this live session would only be like 30 minutes more, 20 minutes more, generally 3 hours, one module, my dear. Shally, we do 2 to 3 hours, one module, depending upon the modules we had. Yeah. So previous neonatal invasive GPS diseases, we have to understand that, but all the rackets are available, Shally. So the students like who are busy in the hospital, they listen to the racket there. If at all the patient's baby had GBS, what do you guys think should be the recommendation? If in the previous pregnancy, the neonatal invasive disease was there, the baby was affected in the previous pregnancy, do we need to test? Shaista, what are we going to do here? What do you think, Sophia? The baby was affected. So what do we do in that situation? Like, for example, mother comes to you in the pregnancy saying that my previous baby had GPS septicemia. We don't even need to test, because this itself is a solid indication to give IAP. Got it, everyone? If the baby was affected, then we don't need to test the mother. Yes, if the mother was affected in the previous pregnancy, we need to test the mother. Is this point clear to you guys? If the baby is affected, then 100% IAP is there. Do you guys understand? If the previous baby in the previous pregnancy was affected in previous pregnancy, then 100% it's IAP. If mother in the previous pregnancy was affected, then we do testing or IAP. This difference you need to understand. Am I clear about this? If baby was positive in the previous pregnancy, then 100% it's IAP. We need not test the mother for the upcoming pregnancy. This is a confirmed question 2019, 20, 21, 22, 23. Every time they're fond of checking that you guys know the difference when mother was in the previous pregnancy affected or baby in the previous pregnancy was affected. If any patient, she starts running fever, it is an indication of IAP, please. Even if it's a single temperature, more than 38 degrees Celsius, right? Please keep a note of that in exam. Of course, a positive mother would have IAP, but a febrile patient is an indication despite she was or she is or she's not checked. Fever itself is an indication of intrapartum antibiotic prophylaxis. Is this point clear to everyone? Are you guys following me for this? These 2 points are very important from the Irish prospect. Please do not forget, because you'll get the single best answer. 4 to 5 lines of scenarios will be there and you'll get a question from this. Okay, now, Shaista, what is recommended in the Green Top guideline? Green Top guideline GPS, guys, what's recommended for the antibiotic? Sophia, what is recommended for the Green Top guideline, please? Quick, please. Yes. What is the recommended antibiotic as per the Green Top guideline? What is the name of the antibiotic which is recommended in the Green Top guideline? Yes. It was benzyl penicillin. Amazing. Very well done. It was Noopsy. Sophia, it's benzyl penicillin, sweetheart. Okay, Ghazala Shaheen, happy to see you, my dearest. Benzyl penicillin. Okay, what did I want to tell you? That we used to do, like, for example, the older batches, we used to do the green top guideline. Why? Because we didn't have the Irish recommendation for GPS. So we all were doing the green top guideline for this. Now I will tell you the differences. What are the Irish recommendations they brought in different? So the intrapartum antibiotic prophylaxis, friends, that is basically intravenous benzyl penicillin as the first line treatment for intrapartum antibiotic prophylaxis. And I tell my students how to learn this. We have 3 grams. How do we write B? My students, they know that in the section, I tell them that, see, we write B like this. So B makes, you make 3, right? All of you, please, you agree? So it's 3, and then we make a 1. So it becomes B, right? So benzyl penicillin is IV. That's why we write 3, that is 3 gram, and this 1 to make I, that is IV. So benzyl penicillin is the drug of choice. Group B Streptococcus, benzyl penicillin, and never forget the dose. B is written as 3, so it's 3 gram. Never in your life you guys will forget. Clear? I repeat that once again. Group B Streptococcus. So remember, Sophia, would you forget now? Listen to me and pay attention here, sweetheart. This is, thank you, Sabah. Love to your daughter, my dearest RFA family kids, yeah? This is B, right? So remember from B. Group B Streptococcus, my dear. That's amazing, inshallah, Sophia. So group B Streptococcus, B, remember for B Streptococcus, and remember B for benzyl penicillin. And another thing, you'll never forget the dose if you just remember that B is written by writing 3. Okay? So that is 3 gram intravenous stat. And how do we remember the other? Exactly, Shella Noreen. You just make a half of 3. What is the half of 3, guys? What is the half of 3? 1.5. Right? 1.5. So let's clean the slide and revise once again that the recommended dose of group B Streptococcus intrapartum, group B Streptococcus B for benzyl penicillin, we write 3 in making a B. So 3 gram is the start dose, and then we half it 1.5 gram 4 hourly until the patient delivers. If you remember it for once, never in your life, my students, even in their OSCE exams, they don't have to revise it. They just have these thoughts in mind. Oh, yes, we know it, ma'am, that it's benzyl penicillin. And then we write it as a 3. So 3 gram it is. And then we half it, it's 1.5. Okay. Now, if at all the patient has got allergy or the hypersensitivity reaction to penicillin, so then the recommendation is IV cefuroxime. Now, here you have to please pay attention here. In RCOG, it's not like that. Okay, here RCPI has made a difference in the recommendations. They have divided the hypersensitivity or the allergies in the non-immediate or the immediate forms. If in exam, right, if at all you people understand that in exam you get a non-immediate hypersensitivity. So if you understand that they give you in a single best answer, non-immediate hypersensitivity, you people will be choosing. You people will be selecting from the list cefuroxime. Okay? You will understand that this is cefuroxime that you people would be searching for, but please remember non-immediate hypersensitivity. Right? Non-immediate hypersensitivity. So how many of you like fur? Yeah, we all love fur. We all like in winters wearing lots of wool clothing. Yes. So please just correlate that, the non-immediate hypersensitivity reaction to penicillin. If it's non-immediate, we would be choosing the fur in that situation. And that's an antibiotic of choice, which you people have to remember. Let me reassure that generally the doses are not coming up in MRCPI. We don't see the doses as such, but yes, the names of the antibiotic, let me signpost for you guys that we get at least 3 questions of antibiotics out of 100. Okay, 3 questions we get from antibiotics out of 100. So you should be knowing. And you know what I do? I always, in my MRCOG, I've got 1,030 students. Yeah, Medina, how many are you guys? I think Nadia and everybody has left, yeah, from MRCOG. There are 1,070, I think, in my premium group. They are registered MRCOG2 students with me at the moment, yeah? So they all, I give them homework that you have to make your antibiotics list. Same I do in MRCPI as well. I tell them that you people have got this list you have to make. Why? Because in the end, you just have to revise your stick-ons. Because 3 questions from antibiotics would be coming. Again, doses they don't give, but they do give the medications in terms of antibiotic choosing. All right. And there are certain differences which I'm going to pick up. Okay. So far, am I clear? When are you going to choose the benzyl penicillin? I'm so grateful, my dear. Sarah, thank you, Shelly Gupta. My students would be telling it's been ages of mentorship. So now I think this always say the teaching comes from inside. Nobody can teach you how to teach. It comes from inside. And it's all about the rapport building, and students are the family. This is how RFA works. Thank you so much for appreciation, sweetheart. All those who are listening for the first time, they might feel a change, but other students are used to of this. Yes, Amber. Yes, Shakila, Shazia Shahid. Yeah, I'm so grateful, Sabali. Thank you so much for your laugh. All right. So, we are still having a session. So babies, mute mode, please. This is Shaila's baby. So we'll get back to you, baby, after the session. Okay, so let's go to the next part. Non-immediate, we discussed that non-immediate we'll take a far, and we'll move to the next part, which is different. Now, you all have to remember that back in the previous guideline from Green Top guideline, the recent one doesn't show this, but yes, the older one in the strategy does tell us that prolonged rupture of membranes more than 18 hours. The GPS status is unknown in that situation. Whenever there's a prolonged rupture of membrane, that's an indication of IAB itself, okay? So we consider if there's a history of maternal invasive GPS disease as well. If mother is, of course, having GPS, we are going to put in, right? Now, we were talking about 2 things that was very important about cefuroxime. Yes, exactly, Sheila. That's my RFA baby. Yes. Okay. So all of you, please pay attention here. Benzyl penicillin would be the first line, and then cefuroxime when non-immediate hypersensitivity would be there. Now, this is something different, which we do not have in the Green Top guidelines. So please, all the Irish RCPI students for September, make a stick note on your GPS if you have done from RCOG, please write down this point. If in exam, they give you immediate word. Earlier, what did we say for the cefuroxime? It was non-immediate hypersensitivity. Yes? Here we are saying it's immediate hypersensitivity. If it's immediate hypersensitivity reaction to penicillin, this is the change which RCOG declines using. That is intravenous clindamycin 900 milligram every 6 hours. And let me tell you this, that clindamycin is, because of resistance, is not being used in United Kingdom. You would never choose clindamycin in GPS sitting in MRCOG exam, but here it would be the drug of choice if immediate hypersensitivity is there. Point noted, everyone. This clindamycin, it's a very, very important point which differs. And if I give you 10 points, which are like must coming exam questions, which I give you in the end, like 30 days before your exam, this is one of the question which is so highly potential chances of coming up in exam. Why? Because that's absolutely contradictory to the recommendations which we have in GPS GTG. Do you guys understand this point? Yes, they say do not choose clindamycin because of the resistance. Here, the RCPI January 2023 recommendations, they say that if immediate hypersensitivity is there, please choose intravenous clindamycin being the best one. However, we should be clear that GPS is isolated and is known to be susceptible to clindamycin. So here, we would be choosing clindamycin in MRCPI. Could I make myself clear? If at all clindamycin is not suitable, then Sophia, my dear, are you there? Then vancomycin would be coming up, which you mentioned in the first time. Yes, that's what you have to remember. Could I make myself clear? Did you guys understand this, please? Yes. So you should be able to pick up benzyl penicillin 3 grams. then cefuroxime in non-immediate hypersensitivity, and then IV clindamycin in immediate hypersensitivity. Your exam questions would be super easy if you have this point. Yes, you're right. Vancomycin is chosen. Absolutely, Sophia. But it comes lower down in the selection. All right. Very well done. Okay. So we recommend the GBS rectovaginal culture at 35 to 37 weeks is done. And we consider for those who disclose that immediate hypersensitivity reaction to penicillin is there. So we check that they are susceptible to clindamycin just to avoid the resistance part, right? As I've told you, any patient who is pyrexic, who is running fever, who is febrile in labor, that does require broad spectrum antibiotics. Please keep a note of that in exam. They ask you in exam that if the patient is febrile, she is in labor and she's running fever more than 38 degrees Celsius, then here you choose the broad spectrum antibiotics intravenous. They should be covering both the organisms, Group B Streptococcus and E. coli. Again, this is a potential single best answer coming up in exam, that febrile patient, we need to cover up 2 organisms rather than 1. Okay, yes. Now, why do we give this GBS prophylaxis? My question to all of you is, we give it because we are concerned about the mom, or we give it because we are concerned about the baby? Sheila, Amber, Shakila, Sophia, Shaista. We give it for the baby. You guys are amazing. Yes, we give it because we are concerned that the mother transmits it to the baby. Correct? Yes, the mother transmits it to the baby. All those who are silent in the chat box, please. I need your attention and everybody to be active, please. Yeah. Thank you so much. So if the mother is not going into labor, if she is having cesarean section, for example, if the mother has got an intact membrane and we are having the lower segment cesarean section, would we give intrapartum antibiotic prophylaxis or not? What do you guys say? I mean, is the baby getting exposed to the genital tract or no? Very well done. They say generally, if it's a pre-labor, Rasha, my dear, they say if it's a pre-labor cesarean section, then it might not be required. But if it's an emergency cesarean section and she has taken labor or the membranes were basically ruptured, then it would be the situation where we might have to give her the intrapartum antibiotic prophylaxis. Absolutely, Sabah Ali. Absolutely. If it would be an emergency cesarean or the membranes have been ruptured, then we are going to give the intrapartum antibiotic prophylaxis because we are concerned. If it's a pre-labor prior to the contractions, it's a cesarean section, then it would be generally, we don't require the intrapartum antibiotic prophylaxis. Okay. So we have different sepsis guidelines. There's no contraindication if the GBS colonization is there. Sheila, if GBS colonization is there, can a mom breastfeed? Yes, Sophia? Can a mother breastfeed if the patient, she has got GBS colonization? Yes, it's got nothing to do with the breastfeeding, right? Latching can be absolutely safe. It's not a problem. Yes, genital tract is a problem. Rosina? Yes? Okay, thank you very much, Maria. Happy to see you. Thank you very much, my dear. So all these you people have to remember. We generally suggest that investigations of the sepsis evaluation in an infant should include a blood culture obtained in a sterile fashion. That is a full blood count we check for the baby, and the lumbar puncture can also be done now. We did benzyl penicillin for the mother, all of you, as the first choice. What was the dose of the benzyl penicillin? What was the dose of the benzyl penicillin? We give benzyl penicillin. What is the dose? Very good. Is it 3 milligram or is it 3 gram? No, I don't want 3. I want the scale, measurement scale. Gram. Okay, thank you. So these tiny things that disturb you under the stress of exam, sitting in the exam when you're doing the single best answers, right? All of you, please, when it's a baby, then we add on for the baby with septicemia, we add on gentamicin with benzyl penicillin. So this is different. Baby is Benjen. Everyone, please. For mother, it was benzyl penicillin. Group B, Streptococcus. B for benzyl penicillin, 3 gram was the dose, and then we half it to 1.5 gram, right? Here for the baby, the regimen which is used is a combination because baby needs a little more aggressive management. So it's Bengen for the baby. All of you please remember, it is benzyl penicillin and gentamicin. Clear? Benzyl penicillin and gentamicin. So the baby is going to be Bengen. Now, this recommendation has not been anywhere other than this guideline Irish recommendation, which is, have you heard about any twins, Sheila? Have you heard about any twins recommendation for GBS in the Green Top guideline? Here we have it. So the recommendation, key recommendation number 18, that says that if the patient has got twins and one of the twin is septicemic, please consider treatment to the other twin as well. And this is the only recommendation which Irish guideline is giving us. They're saying that if the one of the infant out of the multiple pregnancy that is a twins is having the symptoms and is early onset GBS is there, they say that we suggest commencing treatment with the IV antibiotic where a sibling has got a positive culture as well. Do you guys understand? Absolutely, Sabali. This is the recommendation which we don't have in GTG. Could I make myself clear? Do you guys understand? So if one of the baby is positive for GBS, the other sibling has to be given IV antibiotic. Shazia, this is the new recommendation, which was not earlier. They've just made this recommendation now in 2023. Why am I coming up with the new things? Because I expect when these things which have not been touched earlier, they will be coming up as a single best answer. Those 5 to 7 questions which are new, these type of recommendations which come up in your exam. Okay, yes, this is in January 2023. January 2023 publication I'm discussing with you guys just 4 months back. All right, okay. So all of you, please keep a note of that in exam. As I've told you earlier, that the GBS UTI in the midstream urine that needs to be given antibiotic now, we did it in the first recommendation. And then we have to do the antenatal treatment if it's more than 10⁵ colony forming unit, and it would be intrapartum antibiotic prophylaxis as well. Moreover, when the patient is discharged with a positive result, we can share with the general practitioner as well. GP should be knowing so that GP can do a good follow-up and we have a good amount of circle of care for her. All right. So all of you, please, all the 2023 guidelines, if you open up your portal, there are wonderful algorithm charts which are made by the moderator for you guys. All those charts start revising side by side because from 2023 publications, they give 2 stations here in the OSCE as well. MRCPME OSCE that shows that, the college has got an inclination towards those topics. Wonderfully, all the summaries, the algorithms had been gathered up together for you guys. You people just have to revise those algorithms again and again because the questions are expected from this. Like the GPS guideline in the Green Top guideline had one algorithm, famous one, which you used to do. Now the Irish recommendations are beautifully in the end. They've given these algorithms and they're amazing, very good memories there. And it's all the recommendations, they get revised just in 5 minutes if you do that. So if it's a planned vaginal delivery, you have a risk factor-based approach for them. If it's a pre-labor cesarean section, we have already discussed no IAP because she's not going through that genital tract. The baby is not passing through it. If the previous baby with invasive disease is there, yes. Which one, my dear Amber? The previous one or the one which, the last one? Yes. Sophia, the portal, as soon as you register, immediately the portal gets updated like in 60 minutes. So the way you log in for your registration, the same way on your login credentials, everything comes. That contains all those content which I have given to you in the slide. I'll show that once again. Okay. Yes, Amber, just after completing this algorithm, I'll show the first one again. The name of the guideline, correct? Yes. Okay, I'll show you, my dear Amber, just after completing this algorithm. Okay, let's have a quick revision, guys. So the previous baby with invasive GBS, we offer IAP. The preterm labor, 37, less than 37. All preterm births would be intrapartum antibiotic prophylaxis despite their own colonization. So any baby being born less than 37 weeks would be intrapartum antibiotic prophylaxis. Okay? If GBS detected in the current pregnancy, absolutely, Shazia, would be intrapartum antibiotic prophylaxis. History of GBS detected prior to the current pregnancy, definitely yes, would be either IAP or checking, right? Any patient who doesn't have risk factor is in labor, no IAP. If the rupture of membranes, it's more than 18 hours, we offer IAP. If the mother is febrile, we treat with broad spectrum antibiotic. Which two organisms we need to cover? Indeed, it's a wonderful one. Which two organisms in pyrexic mother we need to cover, please, quickly?
E. coli.
Yes, and?
GBS.
Amazing. E. coli and GBS. Brilliant. Very well done. So for any patient who had a previous baby with invasive GBS, we should test the mother, right? We should test the mother and see whether we need to give IAP or not. Correct? No, it's not correct. We should be knowing that this patient is eligible for having intrapartum antibiotic prophylaxis, whatever is the situation. Very good. So if baby, they give you in single best answer, which is 90% coming up in your exam, it's always IAP. If the mother delivers at 35 weeks, would it be IAP or would it be testing? Quick, in exam, would it be IAP or would it be testing? You get single best answer. IAP, Maria. Very good. So any preterm birth would be IAP. Please keep a note of that in exam. Any patient who is having an induction of labor, we can perform a quick GBS testing. These are high-risk patients. But if at all she's GBS positive, we can have the IAP, of course. Any patient who has got a rupture of membrane and the rupture of membrane's been more than 18 hours, it would be IAP. Okay, more than 18 hours. Again, this is a very important scenario. Let me tell you that in exam, they'll be giving 6 to 7 lines scenario. They start the story with the name. For example, Angie is 28 years. She came to the labor suite with contractions 4 by 5, and they say that for the last 2 hours she's having contraction, or vaginal examination, she is 2 centimeters. So they start the story with lots of scenario based questions are there. It's not single fill in the blanks. Okay, so you should be ready for understanding the scenario based questions. So when we read, you please apply them on a scenario. That if they give you a story of 6, 7 lines and then they say it's more than 18 hours, she had the rupture of membrane. So you have to catch that buzzword. Okay, now I get my point. That she is more than 18 hours rupture of membrane. So it would be an intrapartum antibiotic prophylaxis. Okay. As I've told that previous baby with GBS, IAP would be given. Preterm, IAP would be given. GBS detected in current pregnancy, IAP would be given. UTI, IAP would be given. More than 10^5 colony forming units, it would be an antenatal treatment plus IAP as well. Okay. Intrapartum, if she is positive, IAP would be given, or if it's a prolonged rupture of membrane more than 18 hours, IAP would be given. If she is febrile, then broad spectrum antibiotic would be given that covers GBS and E. coli. And we have got certain treatment plans, and we have got some sort of an early onset sepsis calculator for the baby, which are not required for you, but they've given reference of a nice guideline in this. Okay, so the risk factors for the patient is any patient who is having fever of 38 degrees Celsius or more, rupture of membranes more than 18 hours, preterm delivery less than 37 weeks, GBS colonization in the current pregnancy or in the previous pregnancy, we test or give IAP, bacteriuria in the current pregnancy having GBS. If you remember these risk factors, we understand that she is on risk of intrapartum antibiotic prophylaxis. And I repeat, 2 to 3 questions of your exam would be done on this. Let's have a quick revision on the recommendations of the antibiotics so that you don't forget. If the patient has to have the intrapartum antibiotic prophylaxis and she doesn't have any penicillin allergy, what would be the answer in that case? If she doesn't have penicillin allergy, benzyl penicillin would be done. Yes? Perfect. Yes, Savali. Now they say we would be testing. Now, Afshin, if non-immediate penicillin allergy is there, non-immediate is there, then the first line would be very good, cefuroxime. And second line, they say clindamycin and vancomycin. But if severe or immediate penicillin allergy is there, then the first line would be clindamycin and second would be vancomycin. No cefuroxime in severe or immediate. I repeat once again, non-immediate penicillin allergy, cefuroxime B is the first line. Severe or immediate penicillin allergy, clindamycin is the first line. All right. In non-immediate, we can put Clinda and Vanco as a second or a third. And in severe, only vancomycin, as Sophia was saying, that it is an important recommendation for antibiotic. Okay. So they've given this chart with you guys. So please keep a note of that in exam. If we say, as per the recommendation of 2023, if a patient is febrile, shall we test her for GPS or no? What do you guys say? Shall we test her GBS or no?
No.
No, we should give
Why?
her antibiotic.
So you don't want to test her? We don't need to send the swabs, is it? Effort. No? Sava, no? Shella, no? Marian, no? Okay. All of you, please, we test her, we don't test her. We have to give intrapartum antibiotic prophylaxis. So they give you this question and they give you option number A, send the swabs. And then they give you intrapartum antibiotic prophylaxis. IAP is a recommendation. It is a recommendation, despite it comes out to be positive. But in intrapartum pyrexia, we do all the investigations that related to the chorioamnionitis for the patient, but it doesn't make any difference in terms of IAP choosing. IAP is recommended for these cases. All right. Okay. So please keep a note of that in exam. These tables are given in the end. I've made you learn these tables now. These tables should not be a problem. Take a printout and attach it to your infection module. When I'll do the infection module, I will tell you that how you have to revise, and the moderators will do certain questions from GBS in the group as well, so that you solve more and more single-based answers and it becomes easy for you. All right. So as per the Irish recommendation, guys and gals, GBS disease is a mandatory notifiable disease under the infectious disease regulations. That's why the Irish College has made its own recommendation, because that's important for them. Thank you so much for being awesome students today. Thank you for lending me your important time and the precious time we did at the GBS. It was just a glimpse of one of the sessions which we will have in the infections. And this is how we are going to cover up all the guidelines. As students, they say that the sessions themselves are sufficient for them. And the way we read, we do not only read the guidelines, we learn them, we memorize them. We try to make it so interactive that they know while sitting in exam that, yes, I'm ringing in ears, and they make their decision. Thank you so much, Maria, my dear. Thank you so much.
Thank you,
I'm
ma'am.
so
It's
grateful.
wonderful
So,
season.
thank you so
Wonderful
much.
session.
So grateful. Thank you so much, my love. Thank